Well, thank you very much, Molly, and good afternoon, and welcome to the Bakken Center for Spirituality and Healing Wellbeing series. I'm Dr. Mary Jo Kreitzer, the founder and director of the center, and for more than 2 decades, we've been advancing health and well-being in people, organizations, and communities. We are delighted to be hosting our Wellbeing series speaker today, Dr. Alonzo Plough, who will share his presentation, Wellbeing, Expanding the Definition of Progress. During today's presentation, Dr. Plough will discuss both the national and the international context of well-being research, with a focus on developing evidence to improve policy and practices. At the Bakken Center, we've been focusing on health and well-being for nearly 3 decades. Many of you are very familiar with the center's well-being model. Our mission includes conducting rigorous research and advancing innovative education and models of care that are well-being, whole person focused. And we have a keen interest in policy that advances well-being for all. Today's free lecture is made possible through the generosity of our university donors and individual donors. Thank you for your commitment to the health and well-being of people in Minnesota and around the world. It's my honor to introduce our speaker today. Dr. Alonzo Plough joined the Robert Wood Johnson Foundation as Chief Science Officer and Vice President, Research, Evaluation, and Learning in January of 2014. He also oversees 2 grant-making portfolios, Pioneer and Global Ideas for U.S. Solutions, which focus on innovation and emerging issues. Dr. Plough has been a national leader in public health practice for more than 25 years. He came to the foundation from the Los Angeles County Department of Public Health, where he served as Director of Emergency Preparedness and Response. And in that role, he was responsible for the leadership and management of activities protecting the 10 million residents of LA County from natural disasters and threats related to disease outbreaks and other public health emergencies. Dr. Plough earned his PhD and MA at Cornell University and his MPH at Yale University Schools of Medicine's Department of Epidemiology and Public Health. He has held academic appointments at Harvard University School of Public Health, Tufts University Department of Community Medicine, and Boston University School of Management. He is currently a clinical professor of health services research at the University of Washington School of Public Health in Seattle. He has been the recipient of numerous awards for public service and leadership and is the author of an extensive body of scholarly articles, books, and book chapters. Welcome, Dr. Plough.
Well, thank you for that very, very kind introduction, Mary Jo, and very, very happy to be here. And I can see from the chat that we have participants from all over the country, but I spent 4 years in Northfield, Minnesota, so I hope spring is kind to you Minnesotans, because often it isn't in terms of weather, but let's hope. I'm going to be talking about building a culture of health and equity through well-being, and I'll be focusing a lot on well-being as what we believe at the foundation, and I believe from being in public health practice for many, many years, is really essential if we're going to achieve beyond just the measurement of illness status, but true well-being in our country. So, and we believe at the foundation that the focus is on well-being and health, and particularly on addressing health equity. So that's the framing, and we will have time at the end of the presentation for questions and discussion. So let me move to the next slide, please. So a little bit about the Robert Wood Johnson Foundation, if you haven't learned of us before. Started 50 years ago. Started with a generous gift from the founder of Johnson & Johnson, but we have been completely separate from J&J for 45 years. And we are the largest philanthropy solely dedicated to health in the United States. And it's just a privilege to be at the foundation. I've been here 8 years, and the role that we are able to play in being a voice for health and well-being in the United States and around the world. Our focus areas within the foundation broadly, I wanted to mention this so it helps to describe how we approach well-being. Transforming public health and healthcare systems. Certainly, the COVID experience lets us know how much we need to transform those systems so that they address health equity and prevention in a more robust way. We do a substantial amount of work in those areas. Healthy communities, particularly improving those conditions so that well-being is a possibility for all. I will talk more about the importance of community well-being in the other parts of the presentation. Healthy children and families. Clearly, health, well-being, and community health starts with children and families. And children and families in this country and around the world need equitable opportunities for thriving. Again, not just less a prevalence of disease, but actual thriving. And that's why well-being thinking and even well-being measures are so important for our aspirational goals around equity. And then leadership for better health. And again, not just conventional leadership from people with titles and positions that sound like formal leaders, but leaders deeply embedded in communities and in all of those systems, health systems, other systems that have influence on these social determinants of health, so that we are allied around this mandate and the importance of a culture of health. So next slide, please. I think all of us know that a vision of community well-being, what I'll talk about in a minute more about a culture of health and well-being, is a worthy aspirational goal and a necessary one. But all of Americans are not able to achieve that equitably. This is a shot of Chicago's South Side, and illustrative of the nearly one-fifth of all Americans live in neighborhood conditions that really make it hard to be healthy, make it hard to see well-being as a goal or an aspiration. And it is the result of a legacy and a history of inequality. This is actually part of a slide set I used to show the differences within a small area in Chicago during the terrible heat outbreak in the late 90s, where in this neighborhood many people died as a result of that heat, and then just a few minutes drive away in another neighborhood that didn't happen. So this inequality of place, these conditions of place, which really are the cornerstone for achieving community well-being, becomes really important. And a lot of the work that we do at the foundation is around how do we address this through health equity. Next slide, please. I want to return to this issue around these small differences in health and well-being, big differences rather, in small geographies. Now, this is New York City, and but it could be anywhere. It could be Minneapolis. It could even be here in Princeton, where I am now. But when you see these approaching double-digit differences in life expectancy at birth in small geographies, again, you can see those differences between Harlem and the Upper East and West Side in New York City, but you see those same 10-year differences between leafy, bucolic Princeton and Trenton, just 7 miles away. These short distances to large gaps in health, large gaps in community perceptions about the possibilities of well-being, and the kind of despair intergenerationally that occurs because of these conditions when they aren't remedied. It kind of goes to the core of how we speak about the need for a well-being movement being addressed through this issue of health equity. Next slide, please. So I came to the foundation 8 years ago now from Los Angeles to help us begin this framing of our work around building a culture of health that started around this health action framework, which some of you may have seen before. And I want to spend a little time on that because it will situate the things I'm going to talk about later. When we looked 8 years ago at what we needed to do as a nation, we realized that we were calling it a culture of health. And that simply means we need a collective sense that we are all in this together if we are going to have health and well-being in the nation. And Mary Jo and I think have used the same language. We have to get from me to we as a nation if we're going to have the preconditions for what it means to have health, well-being, and equity. And as we approach this at the foundation, we came up with these 4 areas that we thought were really important in trying to make that transformation happening. One was making health a shared value, making health a shared value, not just the absence of disease, as we learned more than 50 years ago from the World Health Care Organization about health. But how do you make that a shared value? And how do you make that a shared value in a me to we kind of context? This action area 2, we know that those of us working in public healthcare systems are a major part of what it's going to take, but it's going to require much more collaboration across many more sectors if we're going to improve health and well-being, particularly those conditions of place, neighborhoods represented by the picture I showed you from the south side of Chicago a second ago. It's going to take economic developers, bankers, a variety of other sectors working together, sharing this vision to improve well-being. It's going to take, as action area 3, creating healthier, more equitable communities, all communities. Our health is interrelated. Pandemic shows us that. Disasters show us that our health and well-being is really a collective enterprise. And how do we create those equitable conditions in places so that that can happen? Fourth, certainly, and this was the foundation's traditional work on strengthening the integration of public health and healthcare systems, continue to do that, but all to improve population health, well-being, and equity. So that's how we see this. You see the equity issue around that, and we can talk maybe in the Q&A in more detail about the difference between equity and simply equality. Next slide, please. So we're looking to build a culture of health where everyone in America has a fair and just opportunity for health and well-being. And we've been working on this definition now and refining and operationalizing this definition over the last year. It is an inclusive definition, but it particularly because of the equity focus, our work leads us to believe that everyone will not have a fair enough, everyone has to have a fair enough, just opportunity, but we have to take a particular focus on those who have been marginalized and not had access to the conditions of place and life that allow that to happen. Next slide, please. So I would, anything that I'm saying that you'd like to learn more about, it is in our website, rwjf.org. So please go to that website. Not right now. That's for the millennials who go right to links while I'm talking. But don't go right now. But the definition and a lot of backup stuff is on the website. So health equity means that everyone has a fair and just opportunity to be healthy. Well, that's aspirational, but that's not specific enough. So what does it require? It means looking at these obstacles. What is getting in the way? What is getting in the way systematically to health? Poverty, discrimination, racism, and all of their consequences. Powerlessness. We do a lot of work now on building community power as a pathway to health and well-being. And again, lack of access to good jobs, education, housing environments, all of these objective determinants, objective measures of well-being are all really essential if we're going to get at this. And I refer you, the sources, our monograph series on health equity, which you can also find on our website. This is the first one that we did with my colleague Paula Braverman at the University of San Francisco, UCSF. Next slide, please. So what are these barriers? We see them in all of our work on the community side of well-being. Again, the historical legacy of structural racism and other marginalizing structural factors. Residential segregation. It's impossible to get a sense of we-ness if we are not living in a context where we are living on a day-to-day basis with other people that are different from us, apparently visually different from us or culturally different from us. Housing affordability, poverty, lack of equity in educational systems, lack of access to healthy foods and affordable foods, poor air quality, greatly compounded by the biggest threat to well-being I can think of, which is climate change. Community policing concerns. This is a slide I've used for years. This preceded the events that you experienced, those of you in Minnesota, with the murder of George Floyd. But again, community policing and having a sense that public safety is actually a public health concern and a collective concern, clearly a barrier to health and well-being, many, many more. So we work on these things and see addressing these objective determinants of well-being as very critical, both in our measurement of well-being and in our programmatic work to address policy changes needed to get at some of these barriers. Next slide, please. So what does progress look like for a culture of health? Or what does it look like, progress look like for a culture of health that has well-being and equity at its core? As we talked about in the our well-being book, the Oxford University Press book that is available to all of you for no charge at a link to the our Robert Wood Johnson website, which I think the organizers of this conference will give you. We want to think about well-being as a counterbalance to a conventional notion of progress. Gross national product, that conventional econometric notion of a country's well-being, we think really is not comprehensive or deeply rooted or sufficiently rooted to really get us to a culture of health and health well-being. Not that economic issues are not important, but we need to look at economic issues in a little different way. I'll talk about that later. So what does progress look like? In this country, we do a lot of work, and our partners and collaborators around the country, on changing the narrative, changing a narrative from just simply illness care to health and well-being, changing the national discourse so that we try to understand that these 5-year or 10-year differences in life expectancy are not about deficiencies in individuals, but they're about deficiencies in conditions. These are not vulnerable people. These are generally resilient people in these zip codes that have extreme health disparities. They are resilient people in neighborhoods that have conditions that create vulnerability. How do we change that narrative? How do we adjust the values and our priorities and the way we talk about these problems? And we do a lot of work in this, both at a community level and through research and surveys around what it means to change the narrative. We can talk about that more in the Q&A. But the narrative change should lead to action. How can changing the narrative, a well-being narrative, a narrative that goes deeper than GNP or deeper than measuring disease prevalence, how do we turn that into action? Well, it turns into action around changing policies, particularly in how we invest in local communities, in our federal budget, to build the kinds of infrastructural support, community supports that allow for equity and well-being to flourish. Workforce, wages, all of those, again, the narrative changes, and that kind of work really needs to lead to policy action. And then assessment. I'm an epidemiologist. I'm proud of being somewhat of a measurement wonk in my academic life. We have to have measures, metrics, indicators, not just for how bad things are, but how we can show incremental improvements over time, and assess that we're right on the direction for change. So that involves changing what we measure, our approach to research, our use of data, and really as we begin to research and understand how to improve community health and well-being, data and community engagement that is not extractive of the communities that we work with, but is collaboratively developed with them, meaningful to our community partners, because that is, and I just know this from years and years in public health practice in Boston, Seattle, LA, where I directed health departments. Unless you have that meaningful engagement around these issues at a deep community level, that the changes aren't going to happen, and we need to be able to assess that we can do that. And for those of you who are academics in the audience, we have to really interrogate our research methods and our conventional data sets to really ask the question, are these the best ways to help advance health equity? I'll talk about that in a little more detail later in the presentation. Next slide, please. So we know this, what gets measured gets done. That is an adage, particularly that those of us in healthcare use a lot in the quality assurance. I think we use it also on the business side. But so it's really important, not just because I'm an epidemiologist and I like metrics, but I think unless you have measures or indicators, it's hard to know whether you are being successful in developing and moving things in the direction that you want to do that. And that's certainly important when we're trying to think about community well-being. I think many of you in this audience know quite well that the United States is really behind many other countries all around the world who have well-being policies, have ongoing national measures that incorporate subjective and objective well-being measures, and some are developing economic policies that are driven by those kind of metrics. You see those in the OECD countries, the UK. I'll talk a little bit more about New Zealand later. So, if we're only measuring GNP, if we're only looking at the Dow or S&P index, if we're only looking at disease prevalence and incidence, it's not getting deep enough to help us understand how we improve well-being at a community level. We need individual and community well-being, but I'm going to posit, and I think both my experience in public health practice and my research says that these two things are inextricably combined. You cannot have individual well-being if you're really going to not think about what community well-being looks like. What are the current gaps in how we think about this? I'll put some slide to the end where communities and civic organizations around this country have been trying to think about how they measure community and civic well-being measurement. I use the term civic because there's something about being all together on this in a civic way, in a local, even governmentally engaged way that's so important. This other one, how is well-being measurement and equity measurement being connected? Again, in the health side of this, we have tried to move away from just measuring health disparities to understanding what it means to achieve health equity. And at the foundation, we really think a part of that metrics challenge is going to be resolved by bringing in well-being and positive health indicators into our conventional public health and healthcare data systems. I'll go into detail a little bit more about that later. I'll keep coming back to that. It is, again, positing my own opinion on this one. It is impossible for us to have collective well-being in this country, community well-being, without having a clear conversations about structural racism and why racism costs everybody's well-being. And I refer in all my talks, I refer everybody to a book that came out about a year or so ago by Heather McGhee. It's called The Sum of Us. And the subtitle, What Racism Cost Everyone and How We Can Prosper Together. Go out and buy Heather's book. because it really speaks about this problem in a way that should bring us together, both to understand the importance of confronting this, but actually a way and a way of looking at the issue where it's really about all of us together and talks about how all of us will only achieve community well-being through that sort of shared understanding. And then this last bullet on this one's COVID-19. COVID-19 really exposed the relationship between inadequate measures and unequal impact. I just came off of developing a national commission essentially to transform public health data that we put together around COVID, but it also relates to racial justice issues. The lack of positive health metrics, the lack of hyper-local measures, the lack of measures that are meaningful at a community level, all of this came out around COVID and something that we need to address. Next slide. And I see someone put in the chat that Bhutan again is way ahead of us in having happiness indicators. Yes, I was going to have a conference in the spring of 2020 that we were going to go to Bhutan and learn more from them, but obviously COVID got in the way of that. So measurement, taking a three-part look at well-being. So we talk about narrative change, policy change, and the role of measures, indicators, helping us to understand how to advance well-being in that way. Connecting that to leadership, leaders who see that there need to be policy changes driven by and valuing a notion of well-being, and particularly boundary crossing leadership, connected leadership. That's so important. And again, the foundation does a lot of work at leaders at many different levels and how you make policy change. We talk a lot about well-being, or we talk a lot about valuing health and equality, but how do we develop as a nation within states, localities, the linking this rhetoric to accountability? We talk a lot about the importance of children and families, yet we have so many children and families living in poverty, so many working moms not having a livable wage. Again, measurement helps us understand and address that and get past that. And again, connecting these indicators to action. What measures get done if you take action based upon those measures. Again, that is so important, which is why, at least at the foundation, we do a lot of work through our Washington office with connecting our findings to decision makers in DC. Next slide, please. So these are just a view of some of the ongoing RWJF activities to better understand well-being. And I hope the slides are kind of clear. Well-being narratives are so important. I mean, we really need to have a much more robust narrative about well-being. We have, again, go to our website. We have something called the Sentinel Community Studies. We've been working with just understanding community narratives for the last 6 years in 50 places around the country, red states, blue states, urban communities. How are people formulating these problems on the ground around collective action for improved community well-being? Where do they get stuck? What galvanizes them? How do you change a local narrative? What measures make sense? How is this being used at a local level to improve both a sense of connectedness and to address some of these barriers? So I would encourage you to take a look at some of the things on the website that talks about that. Well-being measurement. Again, this isn't a deep dive into that, but one of the things I want to emphasize in this talk is the importance of community well-being measurement, differentiated from individual well-being measurement, and how that can be a pathway to better understanding at a population level equality and addressing inequity. I mentioned just briefly this public health data transformation. If you're measuring the wrong things, if you're measuring it with data sets that lag a year or so behind, like a lot of the federal health data sets, even some of the state-based health data sets. If the data are unlinked between the healthcare side of the health shop and the public health side, if you aren't bringing in social determinants data from other sectors about housing, community development that are so important for understanding fair conditions or unfair conditions in place, you don't have the right data to make the right kind of action. And again, if the healthcare data system defaults to simply disease prevalence and incidence data, you're going to focus all of your already overly focused health dollar on that side of the continuum, and you will recreate and continue to recreate where we are as a healthcare system. So we're doing a lot of work, and you can see on our website the report on transforming public health data toward an equitable and racial justice informed approach to health data in the nation. And again, how we're doing a lot of work, and we think it's really important for all of you who are thinking about well-being around these issues about the measurement, the movement, the narrative, and what information helps to move things. Next slide, please. So again, community well-being, distinct but related to individual well-being. I mean, again, it is so important for us to have this sense of individual well-being, to work on that, to do the kinds of things that help us feel balanced, whole, and integrated as individuals. That's so important. I felt very relaxed doing the music playing before the session started. Those kind of centering activities are so essential. But community well-being is really the intersection of individual well-being and community well-being and others, and these conditions and other things that go on in those contexts that are so important for well-being. Individual well-being is necessary but not sufficient. And I'm just going to go through, the field. I refer you to a study, What Works Well-Being. That's a group in the UK. You can go to their website. Has kind of looked at this, and they are guiding how you can begin to understand community well-being a little bit different way in the UK. And they are going through, I would call this kind of a hierarchy of getting deeper. You can start with just lumping together, aggregating subjective assessments of individuals. For those of you who measure in well-being, Cantrell ladders, things like that. So you can sort of put all that together. You can aggregate and lump together objective assessments of individual scales of life. You can, again, drawing upon existing measurement scales. But these are not really getting deeply enough. You can move that to the subjective side, and again, aggregated at community characteristic levels through surveys. But again, that is still not getting deep enough at the meaning and experience level to understand clearly what some of the drivers are and how to assess this. As you move down this list, as you begin to group together what people are saying, individual narratives about what it takes to have well-being in their community, you begin to get a little bit more deeper and more grounded in experience, lived experience, when those narratives can be collective narratives through conversations community members have together, maybe across even places in the community and people in the community who have differences or are working on more of a sense of community cohesion. Very powerful ways to generate evidence around well-being that can be actionable. And then deliberative forums to collectively define, assess, prioritize community well-beings, trying to get that into policy action. Those appear to be very, very powerful ways of trying to develop more community well-being and meaningful actions down the line. But I refer you to the What Works Well-Being report to go into that a little bit more deeply. Next slide, please. Again, lots of work in the well-being measure space. The well-being book that you can get from the foundation that I edited brought people all over the world who are working on this together, and some of the best thinkers on well-being metrics in this country, Anita Chandra, and one from Rand and others. That are really trying to refine what we mean by community health and well-being. The Thriving Index, Thriving and Flourishing Index, Tyler Vanderway's work at Harvard, that is now being done in collaboration with Gallup, I think is going to give us a national picture of what it means to look at thriving in a more detailed way, and I think will help to expand our focus and understanding of well-being. What are these conditions? What actually promotes health and well-being outside of the usual healthcare system? The amenities and conditions. Increasing evidence that things like libraries, parks, absolutely essential in conditions of place that promote well-being. We are working a lot with what does it take to have people value investments in community well-being, their willingness to see their local tax dollars go to improve these amenities, to see that interconnectedness. Again, on the website, some of the work we've been doing with NORC at the University of Chicago, national surveys that kind of profile how the American public thinks about well-being, and we're all in this together or not, in 7 taxonomies that describe the entire U.S. population. You can go on our website, you can see that index, and you can actually find where you fit in one of those 6 or 7 categories. And then cross or intergenerational capture of well-being, particularly at the community level. There's something about what gets in the way of well-being that is intergenerational, particularly, again, an impact of structural racism is just the true lack of intergenerational wealth in racially marginalized populations. How do you understand that historical impact? How do you address that at the community level? Very important kind of work that's in development. Next slides, please. On this one, just again, we're foundation, evidence-driven foundation. We've just been asking everybody around the world what you need to do, and I won't spend a lot of time on this one, but we got a lot of dashboards that track components, environment, social determinants of health, but we really are trying to figure out more deeply how this really links up to actionable information. What's the most important thing at a community level to focus on that? And yes, war really does get in the way of conditions for well-being, as someone just said in the chat. Inequality and community well-being, again, talked about that, addressing it. Understanding culture, deep culture, heritage, and how that connects community well-being. We work a lot with indigenous populations and communities across the nation. All of these indigenous communities have their own particular history and heritage with the assaults that have happened since the Europeans came to this continent. Very important to understand that throughout the country. We work a lot on understanding the well-being challenges in those marginalized populations. Something about community well-being is more than just social networks that we study in sociology. What does it mean to have intergenerational networks? A whole notion of social health is emerging that's very important, I think, to look at in this. Again, looking at underrepresented, historically marginalized groups, and particularly with the last bullet, the historical context of why we have places that continually generate the inequality is so important to understand and address that collective trauma that persists. I mean, these small area differences in life expectancy. You can also see that these are cities where interstate highways were driven through black or brown communities, where there are the historical impact of redlining. Those of you who live in Minneapolis, is look at your city zoning map of around 1920. You can find it on the web, and look at how redlining and racially segregated covenants really shaped the development of the city. It happened in many other places as well. How do you deal with that history? How do you deal with that trauma? How do you understand it to get through a collective journey to well-being? You can't ignore the past if you're going to approach equity and community well-being. Next slide, please. Hit it again. All right, and I want to end up different versions of this talk. My colleagues, and particularly my colleagues in the foundation, have said you have got to start ending these things in a more upbeat fashion. So I am moving to the upbeat part of this. What people are really doing. Because I think there is a really upbeat message to this. I think that there is just a lot going on around the world and in the country at a community level that is really, I would call a well-being movement. This is a particular slide, and I hope you can, if I think the slide set will be available to you after this, or if you can't see this one here. But this goes into a variety of different ways that a particular group that's working around the country, Rethink Health, and the link to them, yes, you'll get a PDF of this. The Rethink Health group is working with funding from the Ripple Foundation as they kind of break down, as you can see on the left side of this chart, some of the many dimensions of well-being, both objective and subjective, basic needs, lifelong learning, wealth and meaningful work, housing, thriving environment, and then some of the supports and services necessary on the other side. I always like what Next Health is doing, because I like this notion of civic muscle and belonging, which I think is so essentially describes the dynamics that have to happen at a community level to achieve the kind of well-being outcomes we'd like to see. Next slide, please. I'm encouraged by the kind of belated discussions within this country on what it means to have a well-being economy. Just as I said earlier, this is a long-standing discussion in European countries. But it's so important. And the quote here from Paul Tudor, who is with a group called Just Capital, which we actually work with them a lot. I'll just read it because it's so important. I mean, there's $19 trillion in the private economy, 4 times the public sector, 40 times the philanthropic sector. We are really going to have to lever that sector around the kind of social change that we're talking about when we're talking about a well-being economy. But the Well-Being Economy Alliance, discussions about the circular economy that happened there, I would refer you to that. That is the economic underpinning that provides a counterbalance to GNP thinking. New Zealand has unveiled its first well-being budget. You can read more about that by the person who put that together in our well-being book in the Oxford University Press. So again, but something about a well-being economy is essential to the well-being conditions in place that we started talking about before. Next slide, please. And things we're working on right now to address sort of this problem in U.S. data systems, encouraging conversations with Centers for Disease Control, National Center for Vital and Health Statistics, to begin incorporating well-being data into national data sets. There's something called behavioral risk factor surveillance system that CDC runs in every state. We are working with them to actively incorporate more robust well-being indicators, and to take that down from a state level to at least a county and smaller level, so that we can understand the components of well-being at a more local level. Very, very excited about the work going on with CDC, as well as work going on with a lot of the other major health systems and their data systems around meaningful data that came out of the Transforming Community Health Data Commission that I referred you to. Again, on the website you can find that. Next slide, please. Again, another great local example of a community that's been working on this. This is Santa Monica, California. There maybe other folks from LA on the call. People think that Santa Monica is just folks on the beach, but most of the people who live in Santa Monica are actually renters. You have a lot of different issues there. I like this perspective. This is a homegrown local perspective from Santa Monica as they break down what they believe well-being is for their city, their different components, community, place and planet, learning, health, opportunity, their own measures that make sense to them in their community, and their action through city budget policy operations. If anything, sort of characterizes as data to action, local context of what we believe are sort of the drivers of well-being. Santa Monica is an example of this, but we're working with the city of Atlanta in a similar way, Pittsburgh in a similar way. So I think there are lots of different examples of how this is happening from a ground-up basis. But the Santa Monica Wellbeing Index is, I think, a really good example that grounds what I mean by measures that are locally rooted to action at a local level. Next slide, please. So again, lots of on the method side, lots of different things that are happening for those of you who are researchers. How do we look at this? How do we use social media? Survey research is really antiquated. How can we use social media feeds and other Facebook, all of that to better understand objective measures? How can we get a better sense of what communities are owning and developing in their own narratives? Community allostatic load, we're working on this. Community-based organizations doing qualitative work, ethnographic work. For those of you who are researchers, community-oriented research, collaborative research, non-extractive research with communities. Mixed method qualitative data mixed with more traditional data really helps us understand what improves well-being. And again, there are a lot of places around the country. I mentioned the WIN is Well-Being in the Nation network. That's WIN, Birmingham Community Foundation. A lot of effort on this one, and I would encourage those who are interested to look up some of those places. Next slide. So again, talked a lot about the challenges. All those structural and policy barriers that foster health inequality, primarily among them structural racism, but other structural factors that marginalize people simply because of who they are. That could be gender, it could be sexual orientation, it can be disability or ability status. Any of these structural factors that manifest themselves in policy barriers and conditions in place, they get in the way. I already mentioned climate change is the biggest threat to collective well-being and individual well-being that we have. We don't address this and understand that it is an amplifier of structural racism. Things are not going to bode well. How we can deal with residential segregation and improvement of place without gentrification is kind of like the holy grail of urban development. We work a lot on that. Again, very important part of that, hard to address. Health and well-being concerns related to death of despair. I mentioned that because if we had well-being measures, we would have learned in Appalachia long before we saw the opioid deaths. We would have seen the measures of despair. We would have seen the well-being indicators. We shouldn't have to wait until we have frank epidemics and outbreaks as a triggering device for action. Continuing marginalization of indigenous populations and the lack of well-being experienced by those populations is a huge challenge. So next slide and last slide. A lot of encouraging trends. I've tried to hit on some of those throughout the presentation. Lots of things happening at a local level. You can tell that I believe the catalyst on this is going to be local, committed, innovative local government. Every survey of trust in government is like nobody trusts DC, but most people trust their local government. That's why that has to be action axis of moving in this area. That's where you can get more trust and transparency in decision making. And it is easier to think about cross-sector collaboration within a locality, a region, a place. It is possible to engage people, and we're seeing it all around community residents in that activity, and be able to develop the kind of community level, hyper-local, meaning community data on well-being that can drive those actions, and then incorporate those well-being metrics into related governmental policies. So, next slide. That's all I could pack in 45 minutes. I really hope that you can follow up with the references that I gave you on throughout the talk. I was in my fast talk mode to get through this, so I hope we have opportunities for Q&A afterwards. So thank
Oh
you.
my gosh, Dr. Plough, this was a fantastic lecture. Just outstanding information. And I'm really excited about the questions that have come in. I think we're going to be able to have a really lively conversation. I'm going to start out with kind of a broad question. Somebody asks, why do you feel that the United States, the richest nation on earth financially, lags so far behind so many other nations in identifying, prioritizing, and investing in well-being?
Well, that is the big question, and I'll just I approach that question by first trying to find out from those other countries, how did you get there? And the work that we did, that well-being conference book that I encourage you all to read, is free. We priced it really well. It's free if you if you go through our website. Go. Um, um, how did they get there? Well, they got there by beginning to have a little different social compact than we have, right? So when you have a little different social compact, we have a welfare compact. We have a welfare by exemption contract, right? If you are sufficiently marginalized, I'm just explaining the New Deal and forward. If you are marginalized in sort of the best of times, we will reach out to you with entitlement things, but we're not going to talk about something that lifts up everybody. If you have a different social compact, like you have in many of the European countries, it's a different compact. Everyone needs to be assured of a certain baseline. And I think that, and then with that comes a set of how do we measure this is happening, and what are the nuances of that. So the two things were sort of they're sort of connected, particularly in these European nations that think about well-being. They are ways of keeping their commitment and social contract kind of honest. Our social contract, we measure marginalities and define entitlements.
Yeah, I guess to get deeper into that question is really how do we change the social contract? Somebody frames the question a little differently. I think you'll appreciate this. What have you seen to be the best way to get to the hearts and minds of the average person so they understand that, as Paul Wellstone said, we all do better when we all do better. So,
Paul Wellstone, my Northfield days. Anyway, um, part of this is proximity. I'll go back to to how nefarious residential segregation is, right? If we do not see each other in a daily way, if we do not have proximity and see the essential humanity and great similarity between us, no matter what other differences there may appear to be, it is just hard for us to have a collective we sense of things. We have too many things that I think start with residential segregation. We study that a lot. I mean, this is pretty much close to the way residential segregation works. 80% of the white population lives only with the white population. The things are reverse. About 70 to 80% of other populations, black, white, other racial groups, live in mixed groups. In more diverse settings. So this separation in the dailiness of experience, whether just the dailiness. The workplace isn't a substitute for that, right? The workplace is, as we all know, interestingly structured place, our workplaces. I don't call them communities. So it's our workplaces, but it's day to day. It's the shopping, it's schools. It is community interaction. It's your kids' basketball, softball, teams. If those things do not bring together people from different life experiences and different backgrounds, you're just not going to have that, and you will tend to characterize things by others. So the long, I'm iterating a bit, but I think proximity is the key. Proximity in day-to-day usual things. You discover what I believe anybody will discover, that folks are much more alike than different and have much more shared values than are apparent in media representations of our country.
Mm. So important for schools as well as neighborhoods, to be having that proximity. You had an intriguing slide that looked at the potential role of the private sector. So often, I think people think of solutions being policy initiatives at the state or federal level. So, what ideas do you have for engaging the private sector in solving some of these issues?
It's very important. That's why I put one slide. If we're working on social determinants of health, those determinants are determined by those private sector, and that where capital goes. We have been I keep coming back to housing because we've been focusing on housing as a lever in all of this. So what do I'll just tell you some of the things we've been doing. We've been bringing in the economic and community development world and the bankers. We've been working with the Federal Reserve to really alter the mindset of I'll put it this way, that for a small discounting of the usual rates, you can still make a profit, but for a small discounting, you can do equitable community development, mixed income units, some of the kinds of things we see in Atlanta in purpose-built neighborhoods. You can do amazing things. The banks can still make a profit, and you can do something very good that mitigates the cost of housing and the residential segregation kind of problems. And so we've been working just a lot to change that mindset. We also do it again through something we call our impact capital work. Again, working with that sector to rethink the social purpose of their capital, and to understand the social ROI of thinking about it in a different way.
Well, very, very interesting. So, the next question focuses on homelessness, and homelessness is such a devastating problem in many major cities, particularly on the coast. How have or can well-being indices been leveraged to quantify the severity and the consequences of this problem and spur action?
Yeah, the unhoused are it is just one of the most glaring failures that we have on this one, and I think that it is and again it is a failure of, it goes back to the housing issue, it goes back to the housing affordability issue, and I mean, I'll just tell a personal story. I split my time between here in Princeton and Los Angeles. LA homelessness is out of control, and it's everywhere. And we are all in it together because it's proximate to everywhere, and it's a failure of having adequate ability to create affordable housing for people that are working. Since I live near an encampment, because you can't live anywhere in LA without living near some kind of an encampment. I see people going off to work. I see people taking their children, these are unhoused people, from tents to daycare to work and back. This means that you cannot afford a house or rent in LA, and you're a working single parent, right? So this is, it kind of goes deeply into housing stock. It goes deeply into making commitment, getting past NIMBY issues. I think it's sort of beyond, it kind of gets back to the we versus me business. You have to see that that's why the homeless are not some other. They are part of us, that we have failed to address their well-being needs appropriately.
Well, thank you for that. Somebody else writes, Alonzo, about global mental health challenges at this time. And global mental health is such an issue. There's so much trauma, there's so much heartbreak. There was before COVID-19, even more so now. We all know that we're connected. And so, how do you see global health as being factored into how we look at well being?
Yes, I think COVID teaches us immediately that we are all linked together, and the planetary health movement says that, right? When you're only a plane, when you're a 6 hour plane ride away from most anywhere, we are linked. And I think that is very important, and not just for pandemics, but I think for other things as well. I saw a lot of things coming into the chats about a war in a distant country that people were not paying much attention to, in the Ukraine. I mean, we are linked by that. We are linked by that in supply chain and many things that affect our well-being beyond just the vast humanitarian crisis that represents, and the urgency for us to address that. In this country as those essentially refugees arrive. We are linked to the health and well-being. We need to play that role in this country. I keep talking about climate as a big issue. Climate's impact on food production, drought, is going to accelerate these refugees. There are already climate refugees in this country when from the south and southeast, where a rising sea level has forced people out of coastal Florida and north. I mean, so we have to the global nature, whether it's climate change or pandemics or war, famine. We are not isolated. We only pretend okay, pretend if we believe we are isolated from it. We aren't. I think the pandemic and now the war in Ukraine shows how linked we are to to any global disruption is going to affect our well-being.
I think there's many people, on the Zoom today that so appreciate the way you're highlighting planetary health and well-being and climate change and the importance of that issue. And it's another one that our country has not been a leader in. And it's been really hard to get folks in Washington, D.C. to be elevating that from a policy perspective.
Right. It is. It is. We're working very hard. I think, and I'll speak from someone who's been involved in this for a long time. I think climate activists maybe emphasize some of the the issues like that people can't quite connect with, melting ice cap polar bears. That's all true, but the immediate health impacts of, say, the adverse weather related impacts on health, which can be floods where you are in Minnesota, or tornadoes. It can be it's hurricanes in the south, it's wildfires in California. We have to move to understanding the immediacy, real-time impact of climate change on health and well-being, its amplification of other inequalities, and not just something down the line. It's of extreme urgency. I think the current administration is trying to deal with it. But when we talk about barriers to well-being, the defense, it's a complicated issue. The complicated issue. I don't want to get too political as a 501c3 non-partisan organization, but I think we really need to look at, from a well-being perspective, how we adjust real economic parameters. Like, you just can't switch off of a complete sector on a dime. What does it mean to responsibly develop balanced energy policies and approaches that help us over time begin to mitigate this, at the same time that we urgently deal with the adaptation issues of climate change as it adversely is affecting communities?
Somebody writes, they were so happy to see the CDC partnership that you spoke of. And the question is, similarly, is RWJ working in any way to integrate the measures of well-being with the UN Sustainable Development Goals? And how do these well-being proposals relate to the SDGs?
I'm glad I got that question. This slide deck was getting long, so I took my SDG slide out. What I often say in a presentation like this one, the SDGs came out, they were formalized about 8 months after we did this action framework. If the timing had been reversed, I would have just said to the foundation, we should just adopt the SDGs as our framework and draw a circle around the health specific things in the SDGs.
Yeah. So you see complete alignment.
Complete alignment.
Yeah. So a couple of other topics have come up. How does research around ACEs, adverse childhood experiences, fit into and or support the foundation's efforts of building a culture of health and well-being?
We very much so. We have been working in our area on children and families a lot with addressing ACEs. What does it mean to even move upstream from ACEs? I mean, the methodological problem with ACEs is it's all post facto, right? They have what do you do in our understanding around trauma informed care, which is important, but what do you do? What are the precursors that can allow us not to have some of those traumas in the lives of children and families? So we're working around what does it mean? What does it mean to have an economy that supports child and family well-being so that there is not the prevalence of ACEs, particularly the disproportionate prevalence of ACEs in low-income and marginalized families? So we're trying to get upstream as we also work on trauma-informed approaches.
Mhm. Somebody made the interesting comment. I think it was in the chat, Alonzo. I don't know if you saw it or not, but it was an interesting perspective that we need to change the language in our narrative from families to households.
Yes,
I
I
thought that was
agree.
an interesting
I agree.
perspective.
I agree.
Somebody else writes about another important barrier is domestic violence. Domestic violence, including emotional, financial, sexual abuse, is not just physical, it's rampant with little change in laws, much less in the healthcare system.
No, it is a huge issue and a huge issue as a source of trauma, and it's an area that we have worked in not as an explicit area, but we see it come up in all of our community-based work. And it's coming up in some of the work as something to address as we try to understand what are some of the drivers of maternal mortality that we're concerned about, particularly disproportionate maternal mortality. What is relationship between I would generalize to interpersonal violence. I mean, domestic violence, interpersonal violence. These are important factors in driving the lack of well-being. And we're very much trying to get upstream. What is upstream of that? What is, as an epidemiologist, it is, we've learned how to find indicators of these things happening, right? In DV, in medical records and all of that. But what do what is it that, um, I'm going back to housing again. The relationship between domestic violence, housing, crowded housing, inadequate shelter. They're correlates of this. So we have a tendency to try to focus upstream, going from the problem to what gets at the root causes.
Mhm. So you said earlier in your presentation that people have a distrust of government when it's out in Washington, D.C., but they trust their local officials more. And somebody actually writes, because of the pandemic, many government jobs are moving out of DC, possibly permanently for the NIH, for example. Do you think having federal jobs spread nationwide could help regain confidence in government?
That's a very interesting question. If all of a sudden your neighbor actually works for the federal government and you can talk to them at the grocery store, does that create a difference? Then they become less of maybe it becomes less of those people because all of a sudden one of those people that you're at the school pickup line with them. That goes back to the proximity. I think proximity helps.
Mhm.
And if that helps, that would be great. But I just think it's very important to parse it down a little more granularity because people say no one trusts government. That's when government gets proximate. the New England Town Hall, the local election, the local officials that you might know, the city council members that you see. It's a different dynamic. The school
Mhm.
board, right? Different
Right.
dynamic.
So somebody writes that they have had lived in a gentrifying neighborhood in LA. And being a parent, I've seen many incoming parents, particularly white parents, creating charter schools instead of investing in their local public schools, creating segregation in education. I see housing and education go hand in hand. How do we encourage school integration in gentrifying neighborhoods? And I'll just add on to that question, Alonzo, in Minneapolis, we're going on the third week of a strike by the public school teachers. And one of the big issues in Minneapolis is they have declining school enrollments. And they have declining school enrollments because many parents are opting to send their kids elsewhere.
Yeah, that is such a problem. I mentioned the holy grail of gentrification, solving the gentrification, social justice, inclusion problem. Again, living in LA and seeing that, you, this is why you need a collective community. The schools have to be better. LAUSD has to have more resources. Teachers need to be paid better. If LAUSD was appropriately resourced, teachers were paid better. Um, um, it would lift those schools up, and there would be less reason for someone to move into Midtown LA because they like not having a commute to their office in downtown or Hollywood, but then send their kids to West Side private schools. It would limit that. But right now, it is because of some of the historic disinvestment in those public schools. Speaking to another LA neighborhood stuff, a little more quality at the elementary side, but really problems on the high school side. It takes an investment into the school system, seeing it as an asset for all, and probably the linchpin in community well-being is a well-resourced education system that everybody uses, right? I mean, what a way to create all the proximities that are really needed for us to see each other as a we and not a me.
I think you need to be sitting at the negotiation table. Can
Uh,
we arrange that?
I really enjoyed my time as a public servant, but I'm kind of glad to be reflecting from a different place now.
Mm, they're really tough issues. Somebody else writes, colleges and universities are communities in and of themselves, and all of the topics you've discussed live within a large university community, from housing insecurity to trauma, mental health, and cultural, socioeconomic, and racial divides. How do we change the narrative from solely academic success to well-being, thriving, and belonging? It's a fabulous question.
That's a great question. The group I'm going to talk to right after this, the Association of Schools of Public Health, we're taking that on, at least on the health profession side of the higher ed continuum, right? Because we the academy has to think about things differently. We have to think about research differently. We have to think about data differently. We have to think about the composition of our faculty differently. And it is EDI, but beyond. It also means you know, it means having, if we're interested in well-being, wellness, and health equity, it gets back to some of the things I talked about earlier in my talk. How do we make sure that we have the methodologies, the non-extractive forms of research and community, the right ways of understanding and addressing poverty, actionable research? I think things are a little bit better, but Mary Jo, when you and I were in school, I'm not sure people talk so much in our doctoral programs about the action element. It was right. It was publishing in high impact journals and following the road to academic success. We did that, but I think that we need to broaden the impact or the success parameters for what it means to be a successful academic. I was really proud at University of Washington. It took me a long time, but I was the first person promoted to full professor based upon a newly added fourth leg of the stool, which was community engagement and
Wow.
practice, right? And then dissemination of knowledge and not just peer-reviewed journals, right? Op-eds, editorials, collaborative reports. I think, I think we need to move in that direction within academia to acknowledge knowledge building in different ways than high impact journals. I'm not saying that I'm enough of an academic that I believe, that there's a place for that, but there's a place for other kind of knowledge building that's actionable that universities should reward.
Often when I talk to parents of incoming students and they're searching for a college or a university, I'll say, find a place where your young person can learn about what they want to do in the world, but also find a place where they'll leave a healthier and better human being. And so I think, finding colleges and universities that value this is critically important. Somebody shot me a text and said maybe more universities should have a center for spirituality and healing. So that's an idea. Um, Alonzo, just a couple more questions. You spoke about nations having well-being indices, and somebody put something in the chat about Bhutan. Can you talk about what some of the other beyond Bhutan and New Zealand? What are some of the other countries? What kind of indices do they have? What are they calling them? And how close do you think the United States is to having a national well-being index?
Well, they vary from country to country. A lot of the OECD countries, in Europe, uh, have variations on some of those measures. So I would refer people to the OECD website because OECD does a good job of bringing in people like the finance ministers from these countries to begin to incorporating well-being measures into their economic thinking, right? And with the examples, again, the example being New Zealand, but you see those things in the UK, and you see it in France and other places as well. So they're using a mix of some of the conventional subjective and objective well-being metrics, but they are able to bring those into a higher level of national governmental decision making than we have. At the ministry level, one of the biggest advocates of well-being policy in the UK is a member of the House of Lords. I mean, so we don't have a member of the Senate who I would say lives and breathes and is an advocate for well-being. So we have a ways to go for I think for us to have the um, advocacy at that level of governmental decision making about well-being. We still, and I really have to say this too for all of us folks on this call, that we have a lot of work to do in this country just around the term well-being, particularly when I'm talking to, when I'm just talking to folks in my community, African American community, when I'm talking about well-being, people say, "Oh, you mean wellness, like Pilates? I can't afford that." A health club. I have two jobs and I take two bus transfers to get to each of them. So I think it's incumbent on us who talk about well-being to address that perception. And Mary Jo, I get it all the time when we try to take this dialogue deep into marginalized community. You have to dialogue your way to a starting point. Uh,
Yeah. Alonzo, when we at the center talk about well-being, we actually talk about 6 determinants of well-being health and all the different dimensions of health: physical, emotional, spiritual health. We talk about purpose and meaning because that's very connected to well-being. Relationships. And you've talked so much about relationships, community, and not only the assets in a community, the connectedness, feeling secure. So all the things that erode security erode well-being. And then finally, the environment. And when we think of the environment, we think of not only clean air, clean water, not having toxins, the built environment, and then planetary health and well-being. But I find a very simple definition of well-being comes from the physician, Dr. Atul Gawande, who defines well-being as the reasons that we want to be alive. I want to end on a really positive note. Judith Maisel often puts in very insightful comments in the text, and I think she put it in the text something that I think is just such a great note to end on. She writes, "If this seems overwhelming, it's because it is. Where to start? Find something very close to your heart, and work with others for positive change, for the greater good."
Absolutely. That's why I keep coming back to local and not just, that's where it's going to happen. And I couldn't agree with her more. Start local, start with something that has meaning and valence to people and their collective lived experience and build from there. I don't think the movement for well-being is going to start with congressional briefings in DC.
Good point. Good point. Well, I want to thank you so much, Alonzo, for your lecture today. This has really, been an outstanding an hour and almost a half with you. I also want to thank all of our University of Minnesota sponsors who are bringing in partners who as partners with us, help us bring in speakers like you today. I also want to acknowledge and thank all of our staff at the Bakken Center who helped make today's webinar possible. So thank you all so much for joining us today. Be well.
Thank you. Bye.